So good morning, everyone, and we are starting academic session of this Saturday. We have tricky case of the month. We are going to share a few very interesting and challenging cases which we have come across, and I'm sure that through this you all will learn a lesson which we all learned on our way. Let us start with MRSA infection. I'll invite Dr. Meet Jain to start the session. Meet, please proceed.
Thank you, sir. So today we'll be in the second week of February. We came across two cases of quite severe lethal MRSA infections, and I would like to take you to through the clinical journey of these two cases. So we had a 6-year-old boy who presented to us with pain and swelling over the right thigh for the last 8 days and high-grade fever for the last 6 days. Along with that, we had another patient who was a 12-year-old boy, and he had restriction of movement of the left shoulder for the last 10 days and right-sided chest pain for the last 3 days. So I would like to call the 6-year-old boy case A, and we'll call this a 12-year-old boy case B. So patient A was admitted in a pediatric hospital for management of the high-grade fever. And patient B had a history of high-grade fever, which was followed by the restriction of the shoulder motion. On clinical examination, for patient A had his hip in flexion, abduction, and external rotation position. There was pseudoparesis of the joint, and severe pain was present on log rolling. So as we can see in the image, the right thigh is nearly twice the size of the left.
So Gaurav, usually we see an septic hip or an osteomyelitis. Do you see this much of swelling of the extremity?
No, sir.
Yeah, so that was very striking, that they have kind of a compartment kind of swelling, and whenever you see the swelling of the extremity proportionately more than what it should be with an isolated infection, it should be alarming about this MRSA infection, because the Meet would tell you subsequently that these patients have venous thrombosis, and this venous thrombosis leads to swelling. And other thing is the toxins which they liberate, they can penetrate the soft tissue, and so they have a lot of edema in the surrounding. So whenever you see swelling out of proportion to the underlying infection, always think of MRSA. That's the first lesson we learned. Yeah, Meet, move ahead.
So this was the presentation of patient A. Patient B had a global tenderness around the left shoulder, and his active abduction was limited to 20 degrees. So for patient A, we performed an MRI of the right femur along with the pelvis with both hips, and suspecting septic hip, and it confirmed that there was acute right femoral osteomyelitis along with septic hip, and he also had an echogenic thrombus in the right common femoral vein and the superficial femoral vein.
So, like, usually when what is the indication of getting an MRI? Server is with us. In a suspected case of septic arthritis of hip, Server, do you get MRI in all the cases, or it's just a clinical diagnosis?
No, not always. Not always. In cases such a case, when I don't have any clear indication that what has happened, when or if the hip is involved, probably in those cases we go for MRI.
That's right. Gaurav, your
joint is involved, in fact, nearby joint.
That's right. So Gaurav, your take on it? When would you advise an MRI in a case of suspected septic hip?
Sir, in young kids, I try to get an ultrasound. In infants, I try to get an ultrasound, and if it gives me sufficient information like effusion, then I proceed with arthrotomy. But in younger kids, I mean more than 1 year, I always try to get an MRI to confirm whether there is an underlying osteomyelitis or pyomyositis also.
Yeah, so indication should be one, if the pain or the tenderness is extending beyond the joint, and there is tenderness along the thigh, swelling is along the thigh, because you want to see whether there is associated osteomyelitis, because in that case you might also need to decompress the bone. Second indication is when there is disproportionate swelling of the thigh. So you want to see whether there is any soft tissue pocket. And adolescents, especially, adolescents have high likelihood of having pyomyositis. So you might see some deep infection in the pelvic muscles, obturator internus. Those are the cases. And this case, whenever you see this huge swelling, also ask your radiologist to look at the veins to see the thrombosis, and take an ultrasound, do an ultrasound to make sure there's no associated DVT or superficial venous thrombosis. But for isolated septic hip, no swelling, typical, as you said, ultrasound is enough, and you may go ahead with clinical symptomatology. Yes, Meet, go ahead now.
Yes, sir. So I would just like to mention that we had earlier performed the radiographs for this patient, and the X-rays were normal.
Yeah.
So proceeding with our second patient, we performed an MRI of the left humerus, and there was a proximal humerus osteomyelitis with, as we can see, there's a minimal subperiosteal collection.
Now the history was very interesting. Like, patient did not have much of the respiratory symptoms then, but when the radiologist did an MRI, he found on the adjacent lung side there was patchy infiltration. And the radiologist called me up that, sir, is bachche ko COVID hai kya? I said, I patient came for shoulder pain. So they did the CT scan of the chest, thinking that this must be COVID. And one of the young radiologists called me, sir, this COVID count is 18 out of 25. So that was severe pulmonary involvement with minimal respiratory symptoms at that point. And then we realized what is going on. Yeah. So Meet, go ahead.
So this patient had.
First of all, Server, how would you read this MRI image?
So proximal humerus is the prominent feature here, with some intramedullary changes, and I don't see the periosteum is that much elevated, maybe due to less amount of collection under the periosteum. So this would be osteomyelitis.
Yeah, and we found in further images that this is going right down to the distal diaphysis. So it was a kind of pan-osseous disease with more focus on the proximal humerus. Yes, Meet, go ahead.
So this patient had the extra skeletal manifestations were much more as compared to this. And as sir mentioned, there was the CT scan of the thorax done, which showed extensive bronchopneumonia with a collapse of the right lung, along with left subclavian vein thrombosis. So as we can see in the X-ray, the right lung seems to be far more hazy as compared to the left, and there's also in the CT scan as well, as we can see the similar finding. Along with that, in the color Doppler, we can see that there is a thrombus in the left subclavian.
Right. So Sandeep is here. Sandeep, are you with us? Sandeep Vaidya?
Yes, Molin.
Hi, good morning.
Yeah, so being at Wadia, we have seen quite a few of these. And right, so when the first point that you said, that the swelling is out of proportion to what you see in case of typical osteomyelitis. So that is, suggestive that there is something more going on than the osteomyelitis, and that can be a deep vein thrombosis. And in such cases, it's always good to get, apart from your routine sonography, either an MRI or a Doppler. Ask the radiologist specifically to ask to do a Doppler. Most commonly, it is MRSA because MRSA have what we call the PVL gene or the pantene-valentine leukocidin gene, which is thrombogenic. And in these cases, they are at high risk for DVT. So one thing about these is if you are working in a small nursing home setup, it is always advisable to treat this in a institute where you have the backup of entire, pediatric intensivist, hematologist. I recollect one case, in fact, where they had to put an IVC filter. The child was getting pulmonary embolism. They put an IVC filter, and there were two children throughout my career whom we have lost, who started off as MRSA with DVT and then developed pulmonary embolism, and we lost. So,
right. So
very
now the
important to
question,
identify this.
Sandeep, that's a fine conglomeration of severity of the disease. I agree with you completely. These are not a private setup cases. You should have good association with the intensive care people and hematologist, ID specialist. So now for us, patient was of course admitted to an ICU. He was not maintaining his oxygen saturation. His blood work Meet would show in a moment where very CRPs were in 200s. But how would you proceed now if the child is not maintaining it, the saturation? Would you give focus first on the respiratory clearance, or you would go with orthopedic management, or the blood management? The total counts were declining, the D dimers are high. How would you proceed?
Well, it's a vicious circle. I mean, the primary focus is the bone over here. Unless you clear that infection, the lungs are also not going to clear. So with the high risk, with the, your pediatric anesthetist, fully prepared for all eventualities, there is no option. You have to go ahead.
Exactly. So that's right. You can see this D dimer is 4050. So the patient is already going into DIC, and CRP is 264. Typically, when the counts are not that high in proportionate to CRP, we should suspect the MRSA, because as you said, PVL, that is PVL secreting toxin destroys the white blood cell membrane. So WBC count will not raise, it will decline. And CRP is high. So Taral, what do you have to say for this?
So Maulin, see, there are three types of setups available for treating this. One is your own orthopedically inclined nursing home where you do most of your work. Second are ICUs, which are NICUs and small ICUs, which do take care of critical patients, but they are not equipped with OT. But this is a case which needs to be treated by an institution, as Sandeep rightly suggested. So if you ask me what will you do first, is first shift to an institution.
Yeah.
And not treat in an orthopedic setup or an ICU setup, but it requires more than.
Right. So that's right. And patient was shifted there. And we have very dynamic team of intensivists with ICU on wheel, and so this was the dilemma. And patient was treated with high antibiotics. We usually give vancomycin and clindamycin. Clindamycin is considered to be neutralizing the PVL toxin. We don't have, unfortunately, Khanjan with us. He was to be here on the panel. And after 2 days, we had our pediatric surgeon colleague, and so we did this thoracotomy and ICD insertion and the orthopedic lavage together. So Meet, please take us through the journey of both the cases.
So in the 6-year-old patient with the complaints of the hip, the total count was not raised. It was around 4,600. The CRP was 109. Platelets were significantly reduced at 60,000, and D dimer was extremely high at 8,200. And in our patient with the proximal humerus complaints, the total count was 11,000. ESR was 100. CRP 264. D dimer was 4,000, as we have already discussed. SGOT and SGPT, there was mild elevation as well. And as is our protocol, the blood cultures were sent for both of these patients. So for the next step, what we performed was in our patient with the complaints of the hip, the surgery was delayed due to, as we have discussed, the low platelet count of 60,000. So we transfused platelets and FFP, and subsequently we performed the hip arthrotomy along with the subperiosteal drainage, and a metaphyseal window was made, and intramedullary giggly-saw wire decompression was performed.
So the delay should not, like FFPs and platelets should be infused in couple of hours, and then patient should be taken for surgery. But here this patient also developed a reaction to infusion. So that was the reason of a 24-hour delay before the intensivist stabilized the patient. But otherwise, you should infuse and you take the patient fast for the surgery. That's the call. Yeah, me.
So proceeding with the second patient, we, as sir mentioned, we took a medicine, chest medicine opinion, and a pediatric surgeon was came along with us, and a right side thoracotomy and ICD insertion was performed. And we performed a left shoulder arthrotomy, subperiosteal drainage, and intramedullary giggly-saw wire decompression in the same sitting. So these are the post-op X-rays of our of the patient. So the first patient, the 6-year-old boy, 2 weeks after the surgery, he developed severe breathlessness. Now for this, the HRCT thorax was done, and which showed that there was a right side mild to moderate pleural effusion and multiple septic emboli. So for the same, he had to undergo an ICD insertion, as we can see in the X-ray.
So Jayant is with us. Jayant, are you there?
Sorry, Maulin, was he on heparin as well?
Yeah, so that part has been missed. That both these patients were on low molecular weight heparin.
Yeah.
And we were constantly checking their INR and PT, APTT. So that was there. Now, we saw all the data of this MRSA, and there is a concomitant, affection. This in 2-3 days they would develop lung infection if it has to be, but not after the drainage of the primary site. But this child who had fever on and off, who had the CRP was not getting down as quickly, and then he had subtle chest symptoms. But as you see, both the children required hospitalization for more than 2 weeks, and on the second week his chest problems were significant to warrant this CT and placement of ICD. So both this patient required chest intervention also. So that was a bit new, that we thought that now we did not have this position to put this inferior vena cava filters and all. But as you said, that is done in some centers, and that would prevent subsequent chest infection or meningitis or pericardial infection. Would it have been done in this case? We might have prevented this, but that happened later on. Yeah, yes, Jayant.
So the septic emboli is, I think, different from the IVC filter. IVC filter is to prevent a large thrombus going and blocking the pulmonary artery. So the septic emboli, I don't think you can prevent it really. I mean, it's
microemboli, you mean?
Yeah. And even we have a very good pediatric surgical team with us. I work in a large tertiary hospital with very good intensivists.
Right.
So we largely leave this problem to the intensivist to manage, and just go and see the patient once a day and make sure from an orthopedic standpoint patient is stable. Such patients have a very high mortality rate. So it's really not something that I have ever felt competent to manage or handle. And I think having a multidisciplinary team is extremely important for various reasons. And these children, we have had considerable mortality in this particular group, and it's very touch and go. Yeah, and I think orthopedic management, other than the initial decompression, there's nothing we can do really
Exactly.
to make any meaningful
Yeah,
difference.
so the point of presenting this case is, at times the patient comes to you first, and then you refer to this intensive care team, and at times you have to kind of coordinate everything, different people. But by and large,
Absolutely.
our role is to do the drainage, and rest of them should be managed by this involving different specialists. Yes, Taral.
Yeah.
Maureen, from orthopedic viewpoint, 2 points that we have to look for. One thing is multifocality is very common. So even
Right.
if you drain one side, you have to always keep a watch whether he's developing infection anywhere else. Secondly, even the local complications like need for re-exploration and drainage, pathological fracture. These are the
Yeah.
higher incidence in this
Exactly.
category of treatment.
So that they need, I agree with you, that they need multiple time interventions. Fortunately, this child did not require, this children did not require second surgery, but I agree with you. Yes, Taral?
Yeah. So I agree with Sandeep fully that, all these patients have higher rate of complications. I think Maureen, you manage it very well, did not have repeated surgeries. But the learning points from these cases is that osteomyelitis and septic arthritis, they are now presenting in variety of ways. It's not the standard textbook picture.
That's
For
right.
the young pediatric orthopedic surgeons, fellows who are attending this, I would suggest that every child with osteomyelitis or a septic arthritis you treat, whether it's in a major city or a small city, please take X-ray chest. Please do blood, SpO2 on these patients. Learn to auscultate the chest if possible. If not, at least have a pediatrician to see the patient when you admit. Because these
That's right.
patients can, and when we say blood tests, we always send for CBC, ASR, and CRB. Please add serum creatinine, the
SGPTs.
PT-INR, and SGOT-PT to all these patients as a protocol.
The key thing besides this, we have to be good clinician. Many times chest X-ray may not show the picture because we are not capable of reading X-rays also. But talking to family, talking to child, and learning about the new complaint should guide you about the presence of multiple problems. Most of us, we should not be just the X-ray or MRI doctor. We must be a good clinician to take out all the complaints this child has, to identify them. Yes, Meet, let's.
Maureen, sorry to be interrupting. Just
too much to expect from an orthopedic surgeon to be a clinician. That's why involve the team and let them do that job.
Yes, that's right. Yes.
Maureen, just keeping aside this case, a case which looks like a routine osteomyelitis. Do you choose and give the antibiotics? That's your own decision, or do you involve a pediatrician?
See, for routine cases, we have infectious disease specialists in our town, and we had a word. We involve them, but we start with vancomycin and ceftriaxone for all the cases, considering it as a severe case, severe MRSA infection. We send blood culture and tissue, the fluid culture in all the patients, and in 48 hours we find the report. If that is MSSA, then we de-escalate our antibiotic regimen. But the strategy is hit hard and hit early, and then de-escalate, or if it MRSA and very high CRP, then we add clindamycin also. So first we start with Venco and ceftriaxone. Ceftriaxone takes care of gram-negatives also. So that is our regimen. And after 2 days, we change according to the culture report. What is your
last question from my end? Does it change for neonates? And also the duration of antibiotics for neonates, because most pediatricians, they say that oral antibiotics have no value in neonates. So you have to continue, IV antibiotics for 3 weeks. That is what, the pediatricians say.
I think let us not discuss neonatal thing. It's a wide subject.
I know, but I thought I would just.
And I agree that neonates are absolutely different. And their antibiotic depends on where the infection has come from. Is it was an NICU infection or a community, or patients? It's a possibility of fungal But you are right that they need IV till 3 to 4 weeks compared to older kids. Let's quickly go through the case, and we have a couple of more cases to discuss.
Yes. So fortunately, this child recovered quite well, and after the ICD insertion, it was once he was settled, it was removed, and this was our follow-up from yesterday, in fact. And as we can see, the child has full range of hip movements, and here is the walking video. He's quite comfortably walking, and he has no complaints at present.
Yeah, move ahead.
So this was the patient with who had the proximal humerus affection, and as we can see, this is what he had faced. So he was kept on O2 supports, required regular chest physiotherapy, and this was the other image with the sling is post surgery, and this is his most recent follow-up that we have, and he has full range of motion of the left shoulder.
But before reaching this stage, they undergo a lot of ups and downs. There are a lot of prayers from parents and doctors. So these are really challenging cases. And as Jayant rightly mentioned, there are high chances of mortality. But fortunately, these two cases come in 1 week, and both of them went ahead on healing well without any residual problem. Yeah, Meet, let's go to the second case. Any comment, Jayant? Let's keep
So
the
the only
literature.
thing is
Yeah.
for the really severe osteomyelitis, which is usually MRSA and sometimes PVL, we have found using stimulant even in acute osteomyelitis to be useful to get local control. So when the CRP is 200s, 300s, child is very sick, I think early debridement and not just making drill holes in the bone, but actually taking a cortical window out and completely decompressing the medullary canal and putting stimulant pellets loaded with Vanco and Genta. We have found that to be useful to just reduce the whole inflammatory response and push that child from a high inflammatory state into a sort of healing state. It just flips the child from, whereas if we had, I don't know, I don't have enough cases to kind of conclusively prove this, but our anecdotal experience is that it helps.
So that's right. Fine. By the time Meet gets the second presentation, any final comments, Sarwar or?
Very interesting cases to see. Actually, I haven't faced these type of cases with osteomyelitis and concomitantly other chest problems. Did you ask for the CT chest or the other things at the first instance, or
No, actually the CT chest, when the chest problems are there, we should refer them to the intensivist. The CT chest we got before surgery incidentally because on humerus osteomyelitis, there was a picture of lung and that was showing infiltration. So the CT chest was done. It's not on our prescription, but the intensivist or pediatricians, they prescribe. But it's not a routine. But as Taral said, that we should be looking for chest, their saturations. Some of them, their fever is not going, and they can also develop pericarditis. And we also have seen some meningitis in some patients. So this septic focus can go to different places, and we need to have a good intensivist team. Yes, let's see this COVID era case. Yes, Meet, please take us through.
So this title, Challenges in Management of Post-Infective Phalangeal Loss. So we have a 9-year-old girl who suffered from an undisplaced fracture of the first metacarpal. She was conservatively managed with a plaster. And however, on the 10th day of the plaster, her parents noticed foul smell from the plaster. And so they had it removed. And what they saw was there was a raw area along with discharging pus, and so they went ahead and they were prescribed IV antibiotics, which was started, and she presented to us at the age of 9 years.
So me just stop here. Now, Taral is here, Jayant is here. Now, I have been hearing this for many times, and it is frightened. Now, this family developed so much of apathy with the plasters because they thought that the infection happened because of plaster. So, Taral, when we apply plaster for simple fracture or a buccal fracture, what do you advise to family that when they should approach us? If they have systemic viral infection, would you consider antibiotics to prevent this secondary infection? What is your advice, Taral or Jayant?
So this was never a fracture. This was osteomyelitis from day one, if you ask me.
But there was a fracture, undisplaced fracture was there.
I would still favor the fact that many supposed trauma, because I have removed many plasters from frank, metaphyseal osteomyelitis cases, like probably a dozen cases I would have removed, where they went with minor trauma and X-ray was done and the immediately plaster was applied outside, and then a few days later they come to us, with unrelenting pain.
So I agree with you completely, because sometimes people, there is a trauma, there is a complaint of pain, and always parents would correlate that child fell yesterday from bed, that might be the reason of this, but they might have an early infection, and sometimes to immobilize, they apply plaster and they don't take care to bring the patient in, and the family thinks that this is the fracture, so it will pain, and they come after some days when there is foul discharge. So I agree, Jayant, with this. So that might be an infection to start with without obvious radiologic thing.
But because fractures, see, undisplaced fractures getting infected without, I have never seen that. The other scenario where infection is mistaken to be a plaster is the only scenario I have seen. I have not seen an undisplaced fracture.
Jan, can it happen that if a child has systemic infection like URTI or ear infection, in a setting of an undisplaced fracture, can it become secondarily infected?
I have never encountered. It can happen, obviously, but I have never encountered that scenario.
Okay. So looking at this, the patients coming to us,
getting infected.
This patients coming to us, someone had applied plaster with fracture. And I also don't recollect that I see previous X-ray of all the patients, but you are right. So I was so frightened that now I've started telling family that if any spike of fever comes, you approach us back, because we don't want it to get second. But in our patients which are coming to, we apply plaster only if there is radiologic fracture. And Tushar had some comment. If pain increase, it can be infection. Yes. So for all the young fellows, whenever you applied plaster for buccal fracture, or even keep the patient in loop, ask family that the course should be downhill. Patient should not have pain. But if child develops pain or fever, you immediately come back to us, because we want to rule out associated or underlying infection, secondary infection. Yeah, Meet, go ahead.
Right. So the initial presentation was post-discharging sinus along the crease of the thumb. There was abnormal first metacarpophalangeal mobility, and there was a raw area of the dorsum of the hand. We performed an MRI, and there was marrow edema of the first metacarpal and proximal phalanx. So for this, we performed a debridement of the raw area along with a medullary canal decompression, and slab immobilization was done. 2 weeks later, there was no pus discharge. However, there was persistent first MCP joint instability, and the dorsum raw area showed a good granulation tissue. So this is what we performed. We transfixed the unstable first MCP joint with a K wire, and the dorsum raw area was covered with a split thickness skin graft.
So now here, managing this child at every stage, whenever I say that we need to apply plaster, the family was frightened. Sir, you apply plaster, it will start discharging pus again. So we don't want plaster. So we placed a wire just to stabilize, and our plastic surgeon said that this patient seems non-reliable. If I put a graft and if they remove the plaster at home, you fix it and apply a slab. Tushar, it developed MRSA later on. It developed MRSA, but it was a localized infection, was not like PVL secreting. And this wire looks a bit out from the proximal fragment in the one of the views, but it had a good stability, I can assure that. Yeah, Meet, go ahead.
Yes, sir. So the patient was now lost to follow-up, and 2 months later, they presented to us with this. And as
So
we can
again, their patient had some pain or some, and so they were frightened and they removed the plaster at home, and they got wired removed at the native place, and then now they comes back to me at 2 months, and we got an X-ray. The thumb looked little shorter, and I saw this sequestrum, and this the phalanx was resolving. So, Sarwar, how would you deal with this now? Now, this child is presented with this. Fortunately, the overlying skin looks okay. The skin graft has taken off well. Patient is again frightened of plaster. And this X-ray, how would you? The blood markers are within normal range.
Okay, thank you, Molin. So the proximal phalanx is almost gone. Only a little amount remaining, and the first metacarpal is also eroded, isn't it? So I don't know, but maybe a spacer muscular technique could be a way of managing this case.
Right. So, how would you immobilize or distract it?
I prefer to immobilize with plaster, but your patient and the patient's parents are not
But
helping.
the plaster will not prevent collapse, you know.
I mean, immobilize in this position.
Okay.
In this situation.
Right. So, Taral, Sandeep, Gaurav, any idea? Would you do differently?
As Sarwar said, I think, mescally is a good idea. However, what is vital is we have to understand whether the proximal and distal articular surfaces are intact. Because, what are you going to interpose that into? If that is destroyed, there is nothing.
I think the articular surface of this metacarpal is also gone, probably. And the middle phalanx is almost lost. I mean, the proximal phalanx is almost lost. It's sequestrated. So how would you manage
in that
it?
Case, the infection is definitely settled.
It looks like settled, yeah. The blood markers, there is no redness, inflammation. We never know. It might, exacerbate once we operate upon them. So at least we don't want to do any primary intervention at this point.
So if the articular surfaces are gone, then I have no clue. You tell us what you did.
Sorry?
If the articular surfaces are gone, then I really don't know, how to go about it. You tell us what you did. I mean,
yeah. Taral said imaging. Taral, you said imaging.
Yeah, I think so. Imaging was.
Imaging. I mean,
so just want to tell Molin that imaging of pediatric hand is very specific, and it's difficult because there are special hand coils available. But if you send to an ordinary MRI, they will not be able to do a good job. It will be a very grainy image from which you will not get any information. You need to send to a 3 Tesla machine, which has a hand coil, where a super picture of this joint can be obtained. And you should go for cartilage sequencing. The information you will get from this MRI is whether there is what is the amount of residual cartilage which is still present, and if there is any residual infection present. So I would do MRI at this stage to decide.
I agree, Taral, with that. But to me, like MRI, the child already have one MRI before GA with this young girl required multiple anesthesia. And I would get X-ray of the opposite extremity to see how the articular surface of this metacarpal looks like. To me, it looks like that articular cartilage is eroded. Maybe distal phalanx is looking well, and the middle phalanx. My question is to how would you treat it? Say there is mild infection, mild collection. You have to take this sequestrum out. How would you immobilize it? Sandeep, Taral, Sarwar, Gaurav, what would you, how would you immobilize it? Or you would just debride and apply plaster and come for the definitive management later?
So I will use an X-fix and
Can we
some
use some sort of external fixator like mini X-fix?
Right. So like jazz fixator, as Tushar is saying. So that was our idea also, that we'll put an mini fixator, take the sequestrum out and debride after opening whatever it is. And once the bed becomes dry, we will come back and do the definitive procedure, or just to put a small cement block in between. And as Sandeep said, a musculate technique. And then we apply a plaster. That's what I said. We need to, even though we apply a fixator, we need to support it with a plaster, because the fixator cannot give rotational stability. And again, the family escaped. The patient flied away again then after hearing the name of plaster. So Gaurav, Meet, show what happened further.
So we advised them for sequestrectomy along with an external fixator. However, the patient was lost to follow-up thanks to COVID-19, and they were lost for 2 years. 2 years later, they came with this clinical image. As we can see, the right thumb is grossly shortened, and you can see the function in this video.
So it looks like a rudimentary thumb as we see in radial club hand, The metacarpal, carpometacarpal movement is there, but there is no movement at metacarpophalangeal joint or interphalangeal joint. And due to this, she is not able to do grip, grasp, holding objects. It's like a hypoplastic thumb, I agree. So now, can you show the X-ray, Meet?
Yes, sir. So this was the image at present, and the sequestrum seems to have been resolved at this point.
Yeah. So now, Sandeep, how would you manage this at this point? Now there is no, for 2 years, there is no infection. There is a small bit of sequestered bone piece, but most of them are self-resolved. So let's quickly go through, Amit, what we have done.
Yes. So we exposed the gap non-union site, and we used a fibula strut graft and fixed it with a K-wire. So at 2 months, this is the X-ray that we have. And on subsequent follow-ups, we can see that the graft is, the fibula graft is taking up well. At 5 months, it had almost regained the image of the surrounding bone. So that is when we decided to remove the K-wire, and this was what we have at 1 year post reconstruction. So starting from this, with a rudimentary thumb, she has now reached a nearly normal looking hand, her dominant right hand. This was her functional outcome. And as you can see, cosmetically, there is no difference between the two hands, and she can also grip. She has started to grip objects, and this is the video that we have now.
So the opposition is coming from the
fingers and not the thumb.
From the carpometacarpal joint.
Yeah. The Harsh is asking, how is the FPL function? FPL was okay, Harsh, but as we have to do IP and MCP fusion, there was no, I mean, FPL, whether it is functioning or it was no purpose, we have fused those joints. What we could give is the stable thumb, so that she can grip the bigger objects, she can hold the bigger objects. Now, Meet has not placed this photograph of how she is holding glass and mobile, but she can do that. And the learning point is, what is most important is, when this patient came for surgery, I said, see, the plaster is must. Whatever we do, we put a wire across, fibula, fixator, but this is such a small hand, we would have to apply plaster for pretty long time till the fibula gets incorporated. So before doing surgery, I counseled the family twice that it will not work if you go home and remove the plaster. So that was the key. And whenever we treat phalangeal loss, it takes 4 to 5 months for the grafted fibula to get incorporated, because there is no periosteum left. So it will be a very challenging thing. Server is asking, what is IP and MP angulation? At what angle did you fix? We had to put it. We kept it in an opposition, abduction, extension position, and we transfixed it. And once we removed the wire, there was a bit of carpo metacarpal movement, but there is, as we see, there is no interphalangeal or MCP movement. So it has just given a stable stump. But cosmetically, this is very rewarding for the family, for a girl child. I hope she'll do better with more compensations at other places. So thank you, Meet, for taking us through that case.
Thank you, sir.
One question to everyone. One question to everyone about the closed fractures. Thoroughly is there, Gaurav, Sandeep, Tushar. In children in closed fracture, do you routinely go for antibiotics, broad spectrum antibiotics for a few days?
Never.
Sandeep?
No, never.
Never. Okay.
Yeah.
Right.
Yeah. Any other questions by the time I bring out my presentation? Okay. So why I'm not able to share? Let me see. How you decided? I put a stitch over the finger and I pulled it, and the maximum length we placed that much of graft. That's how we measured. So with a stitch we kept distracted, and then we measured this much graft will be taken, and that's how we chose the length. Now, Meet, you have to come to my room because I'm not able to share this. Let me see. Just a moment. I'd open this window, but
Maulin,
yeah, Tarun.
say something. The length of thumb is very important.
That's
and it's
right.
not how much you can pull. It is how much length of thumb is required for opposition. And a
That's
simple way to do this will be to measure length from the opposite thumb. But most of us have different lengths of thumbs. Even I have different length of thumb for my left and right.
That's
so
right.
it would be what is good enough to get a good grip, opposition grip. And
Yeah,
sometimes
only
for that purpose you may have to use an intra-op distractor.
Yeah.
And then, but if you err on the length, then your function will not be the best.
The only thing is, we kept this tourniquet off and see how much distraction we can do, because sometimes by putting an overzealous length of graft, you may have vascular, vessels may get closed. So that was what, and of course we looked at the other side. So right, let me take you through this a novel concept. You all know abduction contracture is a common occurrence in brachial plexus palsy. So I'll talk about what is it, Is it a misnomer? What causes it? How to assess or evaluate it? What are the limitations caused by abduction contracture? What are the current options we have for the management? And what new method I'm suggesting you here today? So what is Patti's sign or abduction contracture? It's an obligatory tilt of scapula on brachiothoracic abduction, and it is known as Patti's sign. So this child who is not able to keep the arm adducted, the moment you adduct it, the supromedial angle of scapula will become prominent. And in many children, it is very cosmetic disabling. And if cosmesis is not concerned, that shoulder remains drooped. And the young girls, they always complain that their sleeves of their clothes, it falls down. So that's a real challenging problem. And surgically, you always see that when you adduct the arm, the medial and superior angle of scapula will become prominent, you know. So in abduction, the scapula is not prominent, but the moment you adduct, the medial angle of scapula moves. And I always say it's a misnomer. It's not just the abduction, but also the external rotation, passive external rotation, which brings the scapula more. So it's not only abduction contracture, but the antero-inferior capsule is also responsible. So this is intraoperative picture. When we reduce the glenohumeral joint, the scapula become prominent. The moment we keep the arm adducted, internal rotation, and the humeral head is dislocated, the scapula sits down. And the moment you reduce it, the dislocated humeral head, postero-superior dislocated humeral head, reduces to the antero-inferior joint, stretching the antero-inferior capsule. So this is not just the abductor tightness or abductor atrophy, but probably also the capsule is also responsible. Capsular contracture is also responsible. So what causes it? So there are a lot of research being done worldwide, and this is a paper from Cincinnati. Kevin and Roger published it, and they said there is probably atrophy of abductors. They did MRI and they found atrophy in abductors, or atrophy of adductors they found in some. And as I mentioned, I always ask that is it there is also capsular contracture which might be contributing to this. But there is also a newer concept that it is not only limited to the soft tissue, but there is also associated scapular deformity. So Rahul Nath has published the scapular deformity, and he termed it as a shear deformity of scapula. That is scapular hypoplasia, elevation, and rotation. So these children have scapular deformities, and there is a classification of shear deformities. And Rahul Nath has suggested triangular tilt operation, wherein he does the clavicular and acromion osteotomy, so that the rest of the scapula sits in its anatomic position, with a lot of complications associated with this. Now, how abduction contracture affects in our clinical practice, we have seen that family always complains that the one shoulder is dropped, and so the child walks very abnormally many a times. And parents always ask them to make the shoulder straight, and when they make the shoulder straight, they elevate their the arm. So, and as I mentioned, the slippage of clothing is a problem, and sometimes cosmetically it is highly unpleasing, you know. So what options we have? The different surgeons across the globe, they have suggested different ways. Supraspinatus slide or Botox has been suggested by Kevin Little and Cornwall from Cincinnati. I have done it for many times and I have failed to correct the abduction contracture. The reason is very obvious, that there is not only muscle but also capsular contracture and bony deformities. So with just supraspinous slide, we cannot correct it. And supraspinatus is very important abductors and stabilizer of shoulder. So by doing slide, we might be abnormally hampering shoulder function. So that is not a very good option for it. Resection of supromedial angle of scapula is done by Sevan from Sick Kids. So this is okay for very mild form of deformities where there is minimal prominence of the medial angle of scapula, and you just resect it as we do it in cases of Phalangeal shoulder. But it will not take care of drooping of shoulder or the glenohumeral deformity. Peter Waters has suggested to add a varus in derotation osteotomy of humerus. But again, we are performing surgery away from the site of deformity. And secondly, we have to stage these two things. Some patients, once we do shoulder rebalancing and we reduce the glenohumeral joint, then this putty sign becomes more prominent. So these patients would need a second surgery to correct the humerus. And at that time, we correct by putting the arm in more varus, we try to correct at a different level. So, and once you put an implant, you will need to remove the implant. So humeral osteotomy will need multiple stages besides the primary rebalancing surgery. And finally, triangular tilt as described by Rahul Nath to correct the scapular deformity. Now here we are doing surgery of the clavicle and acromion. This both the bones are subcutaneous. So when you are correcting very big deformity, these bones will become prominent. And there are a lot of cases where the non-union of clavicle has been reported. So they have suggested to fix them. There are reporting of failure of fixation. So triangular tilt, although conceptually it's a good operation, it is associated with a lot of complications. So what I have thought and what I'm proposing today is a scapular body osteotomy to correct the abduction contracture. Now the question is how I thought about it. So I was performing a glenoid anteversion osteotomy once, and inadvertently my osteotomy became complete. And that point, the abduction contracture or the putty sign resolved spontaneously. Like before a minute, there was severe prominence of posteromedial angle, and in a minute, it became normal. So I was thinking that what happened, and then I realized that the glenoid osteotomy, the scapula got collapsed from the neck, and it assumed its normal position automatically. So I was always thinking that we should do scapular osteotomy to correct this, but performing scapular osteotomy at neck is not easy. You have important neurovascular pedicles. And then I realized that in Dana Meier's resection for Phalangeal shoulder, we used to perform a scapular body osteotomy and resection. So I thought, why we cannot perform that surgery? So let me show you one case and then we will discuss it. So this 2.9-year-old boy with Narakas 2 with a passive external of only 10 degrees, having severe trumpeting and active abduction of 80 degrees with weak triceps, interrotator, and wrist dorsiflexors. And he had this putty sign. You can see when I adduct, the medial angle become prominent, and if you externally rotate further, this will become more prominent. And the family was complaining that always he keeps the arm away from the chest, and for doing anything, reaching mouth, the scapula becomes very prominent. Intraoperatively, you can see the front view, the back view, and the top view, which shows prominence of the postero-superior angle of scapula. So what was the first step of surgery? It is an inverted L extensive posterior exposure, which we use for glenoid osteotomy, is an inverted L incision. You reflect the fasciocutaneous flap. And once you raise the flap, you find out the areolar plane just below the posterior deltoid. And once you open up this plane, you reflect the deltoid from the scapular spine so that you can see subdeltoid anatomy. And then SS is a scapular spine. Here is a scapular spine. This is infraspinatus. This is the arm, and this is the spine. This is the head end. And the next step is to dissect the conjoint tendon through the axillary part from the same incision. So this is conjoint tendon I have dissected, and this is deltoid. This is arm, child is prone. And once you have dissected that for later tendon transfer, you now go to the spine of scapula. And this is supraspinatus and this is infraspinatus. And you expose subperiosteally the supraspinatus. And your osteotomy will start from a little lateral to the medial angle of scapula, somewhere from here, and it will go down on the lateral border of scapula between the insertion of the triceps and infraspinatus. Okay, so this is teres minor, teres minor and deltoid. So let me show you the figure. So osteotomy would start from here. Just here comes the suprascapular bundle. So you remain away from the suprascapular neurovascular pedicle. Start from here and you go below the glenoid. So below the glenoid is a triceps insertion and then comes infraspinatus. So you go somewhere between them and you complete your osteotomy as if you have done Mears resection. What you can do is you can use an image intensifier to template your osteotomy. So this will look like this. So you will put your wire, which is going from supro-medial to infrolateral. This is the end of inferior end of glenoid. So you have to come little distal to this. And then you complete the osteotomy. The moment you complete the osteotomy, you will see the medial part of scapula moves by itself. It corrects itself. And in this case, this got opened up from the top. So it moved medially, inferiorly, and anteriorly. So this scapula, which is elevated and rotated, it comes back to its position like this. And you see the clinical picture. Then I finished my tendon transfer. And once I adducted it, there is no prominence of scapula. I have not cut the angle of scapula. And these are the post-operative views. You look at the front view and there is no prominence of scapula. There is a back view. There is no prominence of medial border of scapula. And this is the top view. So let us compare the pre and post surgery. So this was before surgery. You can see this. And after surgery, it is flat. This is before surgery, the back view, the supromedial angle as well as the medial border of scapula is prominent. Now it is not seen. And this is top view, which is most remarkably showing this scapula was here jetting out, and here it is almost normalized. So, and these are the clinical comparison front view. So we also got an post-operative CT, pre and post CT for this child. Yes, this is the way we immobilized him. We kept it in about 20-degree abduction so that you can see an external rotation. I have not done subscapulary slides, so I kept the external rotation a little more. But for extended palsy, we kept only 30 to 40 degrees. These are the pre-operative CT scan. And you can see the scapulohumeral angle. On this non-affected side, this angle, if you draw from the lateral border of scapula and medial border of humerus, it is 30 degrees. But on the affected side, it is 60 degrees. So this shows that this is the amount of abduction contracture. There are different other ways of measuring abduction contracture, but there's a simplistic way. And you see, this is the post-operative CT scan. See the amount of displacement of scapula. The scapula has shifted medially, a bit inferiorly, and it has, what do you say, it is protracted, which was earlierly retracted. So there is an opening. The amount of opening we see at the scapular level, that is the amount of correction you have achieved, in the abduction contracture. So this is the front view. Top view, you can see the displacement or distance between scapular spine. And this is the amount of anterior displacement of scapula. Now the question is whether with this scapula will heal or not. But this is surrounded by periosteum all where, and there are all muscles. And we have done Mears resection of scapula, and we have never found issue with the union or malunion of scapula. The question is whether will this alter the mechanics of movement of serratus anterior or rhomboids. So that time would tell us. But at this point, the patient is still in plaster and his deformity has gone. The way the child is walking, his shoulders are looking stable. And I'm keen on looking what is the outcome of radiological as well as clinical outcome of this child. So I have presented in front of you guys before presenting at international forum and would like to know your suggestion, or and I would like to discuss this procedure with all of you. Thank you for your patient listening. Taral or Sandeep, any
So how
thought
do you
on this, or
maintain
Jain?
maintain this opening? How would you make sure that your correction remains maintained?
So Taral, what happens, once you do osteotomy, the scapula takes its own position spontaneously. You do not need to maintain it, because with this deformity, the scapula, which is rotated and translated in front with a bit of retraction, or protraction, it comes to sit in its native position. All the muscles, periscapular muscles, are in tension, and you adduct the arm and you see that the scapula has moved. So even you do not need to move the arm. The medial part of scapula takes its own place because it was probably in tension for long. So the question is, we should perform this earlier rather than later, because in later the scapular deformity becomes more structural. That's what I believe. So I have not done anything to kind of distract that scapular osteotomy. It distracted by itself.
You mentioned the role of capsular tightness over here.
Yeah.
So any role for release of the capsule as well?
So Sandeep, I'll tell you what I have done, what I have thought. First of all, that when the dislocations are superolateral, we can always feel dislocated humeral head behind. And you might have experienced that once you do passive external rotation, the humeral head sits, it goes antero-inferior in a true glenoid, right? So I always felt that if a humeral head has been dislocated for long, there is contracture of not only anterior but also inferior capsule. And once we reduce the humeral head, as that capsule cannot be stretched enough, or there is not much space, it will move the whole scapula. So in few cases, I have done inferior capsular release through the axillary approach. After retracting the axillary nerve, I have released the inferior capsule and a bit of antero-inferior capsule. And once you reduce the humeral head, you can see the humeral head from axilla. It's coming out. In a couple of young children, I saw that this putty sign relieved by this, but for older children, it did not relieve the putty sign completely. So I think that only capsular release is also not a solution, because in older kids, there is already a scapular deformity has set in. So we have to do something more than just capsular release.
And this procedure, I guess, must be in conjunction with other procedures as well, isolated.
Yes. Yes. So you can do the tendon transfer along with this, because infraspinal. See, we do this approach for glenoid anteversion osteotomy, where after doing osteotomy, we do tendon transfer. Here I have performed osteotomy medial to the glenoid, and I have performed the tendon transfer. If you want to release this anterior capsule, you can do it from the front. But this case was a 5, 6, 7, and I could achieve passive external rotation to 45. I can always do a minimally invasive subscap release from this incision. There's no problem.
Good. So we have a solution for this problem now.
I don't know. Like I will present the the result. I shared this with some shoulder surgeons in abroad in Europe, and they say they had doubt that the serratus anterior works with the normal some position of scapula. When we do these osteotomies, its fulcrum changes, and they have shown that this parascapular muscle may not work normally. But I shared my results of Mears resection for Phalangeal shoulder, and those all patients have very good degrees of active abduction and rotation. We didn't see any problem. If you have you done that Dana Mears resection, Sandeep or Taral?
No.
So I was trained in Toronto by Dr. Howard, Andrew Howard. He used to do so. Me and Atul, when we came back, we did about 10-15 cases, and then switch to modified greens. But again, in all those cases, we had never problem of union or movement. So I feel that even this should not have problem. If it works, then it's a real good solution, you know. Fine. So I think if any comment, server or anyone, and then we'll wind up this session.
Beautiful.
Any comment?
One will wait to see the results.
Yeah. So as me, I also want to see how it goes. Yeah, Gaurav, what do you think about this?
Sir, yeah, so it looks very, I mean, the correction looks very significant, but yeah, the only thing is how the child performs, what are the functions after the plaster is removed. I am quite hopeful that that the child will do good. And once we have a follow-up, then we can, I mean, I am thinking of
Yeah.
that if we can extrapolate it in other cases of winging of scapula, which we see.
Yeah, that's right. So that there is one other set of patients with external rotation contracture, you know, after surgery. There also the posterior capsule is tight, and along with that, external rotators are tight. We do arthroscopic posterior capsule release, and at times we are not able to correct it completely. But if we can correct it at the scapular level, then we may not compromise the strength of rotators. You know? So there are different extended indications already in my mind, but let us first see how it goes for this indication, and then we'll proceed further. So thank you very much for your time, everyone, especially Savar for your time, Sandeep, Taral, Jayant. You all were busy and you spared time for this meeting. I'm really thankful. Yeah.
Thank you.
So I'm stopping the recording and then closing the session. Thank you very much.